Folks, thanks for coming on the line with us today. My name's John Dubas. I'm one of the Vice Presidents for Agent Success with Premier Marketing. Today we'll be spending the next hour, hour and a half or so discussing an opportunity here in the state of Texas with a new carrier to Premier Marketing. And that's a new relationship that we have with Baylor Scott and White Health Plans. This is a crucial opportunity for Texans simply because they are the provider of the cost plans that are currently in the state of Texas. And you may be aware of the fact that that situation is changing in the state of Texas for 2019, and it's something that as independent insurance agents we need to prepare for and help our prospects and clients with that situation that is being placed upon them. We're going to do a little bit of housekeeping here to begin with. One, today's presentation is being recorded, and the follow-up to today's presentation will be sent to you along with a link to the presentation we did earlier in the year for Baylor Scott and White, and another link to some additional information that should be helpful for you in discussing the prescription drug benefits that are part of the programs that are being rolled out in conjunction with these plans. The earlier presentation we did with Baylor Scott and White spoke to 2018 products. This presentation will speak to 2019 products. A bit of background once again about Premier Marketing. We are a national marketing organization founded in 1968. We're part of the Integrity Marketing Platform that has offices across the country. We provide insurance programs on a wholesale basis to independent insurance agents, with those contracts being vested and at the highest possible commission levels, with recruiting contracts available to those who qualify. As I mentioned, we were founded in 1968, and a little math tells us that, hey, it's our 50th anniversary. We're proud of that accomplishment, having started as a small family agency in one of the localities in the state of Nebraska. We've grown to a national footprint. We're available in all 50 states, and we're one of the largest producers for a number of carrier partners that are offered through Premier Marketing. And that includes United Healthcare, Anthem, and Meridian Care, where we were and are their largest producer at present. We are also one of the largest producers for a number of the other Medicare Advantage programs offered across the country, and we're proud of that relationship because it's part of our overall insurance portfolio that we offer. In the Medicare arena, we offer a number of Medicare Advantage programs, a very robust portfolio of Medicare supplement plans, and an extensive selection of Part D prescription drug plans, the PDP programs, offered on a standalone basis by a number of different carriers. In addition, we offer life insurance and annuity products, pre-need and final expense insurance, long and short-term care, disability, income products, and ancillary products that are crucial for our success in the Medicare arena, in the fact that they cover dental, vision, and hearing products, critical illness programs, cancer programs, hospital indemnity programs that help fill the needs of our prospects and clients who are taking out standalone health programs, be they through Medicare Advantage, Medicare Supplement, or even ACA programs, or the so-called skinny programs that we're hearing about a lot now. It's important for us also as Medicare Advantage producing agents to speak to these programs, because not only do they cover additional benefits for the folks that we're speaking with, but they are programs that pay immediately upon the policy being issued. And we know that our activity during AEP for Medicare Advantage and prescription drug plans are not payable until after the first of the year. So this is a great way to establish an additional revenue stream that pays before that time. So we have a Merry Christmas as well. As I mentioned, we do offer a full portfolio of Medicare Advantage products, national carriers across the country, regional carriers that are solid options for people in different locales, and of course, we're proud to announce our new affiliation with Baylor Scott and White Health Plans. That prescription drug portfolio includes all the major national carriers and some of the folks that you may not be as familiar with, but are strong options in particular markets. That Medicare supplement portfolio that I alluded to, well, it's a big one. It has the national players in it. It has some of the regional carriers, and it's got a couple of newly offered programs through our organization that include Lumico and Union Security, strong A-rated carriers that offer unique compensation packages and marketing support. The Medicare opportunity we speak to with Baylor Scott and White, well, this particular slide has a video embedded in it. You can click on it and it'll give you a really quick overview of some of the opportunity that awaits us. It's recorded by our friend Chris Iona, who is our guest speaker for today's presentation. We want to give you a little bit of background first, and that is the reference that I made earlier to cost plans going bye-bye. Well, Baylor Scott and White is the company that's offered those cost plans here in the state of Texas, and is a grand opportunity for us to partner with them to make certain that a conversion process goes smoothly and equitably for all of us. It also, however, gives us the opportunity to be aware of areas where the program will not be available in the future, where service area reduction requires our help, and then in certain areas where a non-like-to-like plan switch comes into play that requires an enrollment process. And so a grand opportunity for us in many parts of Texas. There are differences between Medicare cost plans and Medicare Advantage programs, and the first one of which deals with eligibility. Medicare cost plans, well, a person can enroll in them if they have Medicare Parts A and Part B, or Part B only. Medicare Advantage programs require the individual have both A and D coverages. It is also important to note that Medicare cost plan and beneficiaries can go outside of network without a POS or PPO type of situation, and when they seek care outside of the plan's network, well, it reverts back to traditional Medicare coverage. So they have that option to utilize that unique feature. Cost plans also can provide prescription drug coverage as part of the plan, or they also give you the opportunity as a beneficiary to pick up a plan that is a standalone program, much as the old days of private fee-for-service programs within the Medicare Advantage arena did a number of years ago. Those plans aren't available anymore, and it is important to note the difference that Medicare Advantage programs, if they don't have a drug benefit embedded in the program that provides health benefits, well, it's an opt-out of Part D, and they cannot enroll in a standard standalone Part D program and make it work. So it's a crucial difference for us, and one of the things that we need to be very aware of and have a good understanding of and explain very well in the presentations that we have with folks in this situation. It's also important to note that cost plan members are not subject to lock-in. They can enroll in the program at any time that the cost plan is accepting new members, and of course they can disenroll and go back to original Medicare at any time as well. Keep in mind that doesn't create a special election period for them to enroll in a Medicare Advantage PDP program, so that's something we need to be aware of and speak to intelligently. The legislation that's brought about all these changes, well, it's not really sudden. The legislation actually began back in 2016 and was extended, that particular period of transition, by the macro legislation that allowed an additional 2 years for cost plans to transition to Medicare Advantage programs. This all changes come the first of the year. So cost plans where there are at least 2 competing Medicare Advantage plans meeting specific enrollment thresholds available in that market, in that county, well, it's a whole new ballgame then for cost plans because they can't be offered any longer. a big change for us and a circumstance where in the state of Texas, it's a particular interest to programs in 37 counties that are thusly affected in that circumstance. This gives us the opportunity to be who we are and offer our services to beneficiaries across the state to give them the options they have available and help them determine what may well be the most appropriate plan for their circumstance going forward. So it's a grand marketing opportunity for us here in Texas and many other states, because the cost plan changes affect all cost plans across the country, and there are over 700,000 members in cost plans in the United States. The majority of them reside in the state of Minnesota. Over 400,000 cost plan members in Minnesota, with the bulk of those, a big chunk of them anyway, within about a 120-mile radius of Minneapolis, St. Paul. You'll note on this that nearly 30,000 cost plan members are affected in the state of Texas. So this gives us an opportunity to work with programs that are alternatives and to work with the carrier that offers those programs and has a Medicare Advantage option for them, because in those areas, Baylor Scott and White is the preferred provider of care. Remember what I alluded to when we started today's presentation, where 18 of their hospitals are rated as best hospitals in the country according to U.S. News and World Report. Well, that gives you an idea as to where people look to seek care in these affected areas as well. So we're going to be spending the good chunk of the rest of our presentation listening to Scott Iona give us the additional information about the changes that are coming about with Baylor Scott and White, details on 2019 sales opportunities, and additional information about how that affects our marketing plans moving forward for 2019. With that, we welcome Mr. Iona to delve into his presentation and give us an opportunity to learn more about this opportunity. Chris?
Thanks, John. Can everybody hear me okay?
Coming in good.
Oh, perfect. Well, I appreciate the introduction, and I'm happy to say that, yes, we will be going through some of the 2019 benefits. And for everybody on the call, what I want to do before we jump into this presentation is to kind of set it up, because we're going to go through the full summary of benefits for all 8 of my plans in Central Texas and then North Texas PPO that we'll have. I'm going to save everybody the time of going through each benefit line item by line item. And rather what I'm going to do is go ahead and point out what some of our competition has decided to do this year and focus more on ways to position the conversation to sell the plan against any competitor, and then to sell the plan on its own merits. So if everybody's okay, I'm going to skip through some of the summary of benefit slides pretty quick, having only addressed a certain few topics on each slide. But for the remainder of it, what I'm going to do is kind of go through the revamp that our company's gone through for 2017 and 2018. And then I want to talk a little bit about what the transition process looks like from cost plan to MAPD for our existing membership, and where the opportunity for agents is going to pop in or present itself in those transitions. The next few bullet points I'll cover are going to be some of the summary of benefit information, and then I'll go through some of our value-added benefits. The last 4 bullet points on the website, the ordering enrollment materials, annual certification, and contact information, most of that's going to be able to be handled by your upline, but I did go ahead and include some slides in reference to our website and our online enrollment tool. So, yep, let's go ahead and jump on in, John. It's a long presentation, about 50 slides, so I'm going to try to get through it quick within an hour for everybody on the call. If you guys have any follow-up questions, feel free to shoot them to John, and I'll be able to address them through Premier. But to start it off, part of the revamp that we've had is due to the integrated care model itself. You're going to hear that come out of my mouth every time you talk to me, because it's going to be the direction and future of healthcare. Essentially, all of the complaints we heard 10 years ago in this field about doctors not not understanding what the insurance companies were approving, and yet prescribing tests that were not covered on Medicare. We all dealt with a lot of that issue. What it did was it helped us struggle, at least on the agent side, with our credibility, because the rules we're presenting one year are changed the next year. The one thing I want to talk about with our organization is that we understand the federal government and legislation drives all healthcare changes first. What that trickles down to is practical application. Then the rules and the laws make it down to the doctor's level, and that's the person that's really providing the level of care that's keeping our patients alive, keeping their quality of life increasing, and keeping the outcomes good. So why is it important for a health plan to understand and partner with their own hospital system? Because we're able to match data points at the point of care. We're able to explore new avenues of care and share in real time without any lag, which, make no mistake, costs money in our industry to the tune of about 7 figures if something's a week late. But what it did was it simplified that message, and it contributed to better patient outcomes, and it contributed to those outcomes in a faster frequency and a faster timeline. So what Baylor Scott and White Health is the largest integrated care company in the state of Texas. We're one of 3, I believe, in the state, but comparative in size, we're about 55,000 employees, where the next biggest is about 550 employees in their administration department. And we service over 1 million Texans every year with our health insurance products, and more than 1 million when it comes to our hospital systems and our clinics. Part of our revamp has been to align the health plan closer with the physician model and closer with the hospitals themselves. So how we do this and where it benefits agents is we're able to lean on the credibility of our doctors to help explain some of the value-added benefits of our plans to our patients. And we do it in a legal manner. Whenever any patient is brought up to our checkout desks, they're going to have a lot of questions that they're going to be asked by our checkout desk that are meant to diagnose some of the issues that they have with their insurance. Part of the quality scores that we see in the integrated care models are affected, again, by the insurance themselves and how they handle the patient, from income to outcome on the medical side. So as we revamp, you're going to see us working closer with our system to piggyback on some of the marketing campaigns. You're going to notice that our reception in our areas, in our service area, is a lot higher, and most notably, we are the only Medicare Advantage plan with access to 100% of the Baylor Scott and White health system. That's where I wanted to go with this part of the conversation, is to let everybody know there are only 2 competitors that are allowed within our organization, and those 2 competitors do not have full access to our physicians. And in the cases with which they have a doctor in our network, in network with their plan, they're still going to have to deal with referrals and prior authorizations. So with that being said, I'm going to go ahead and jump into some of the plan details itself in the next few slides. You can skip this one, John. Skip that one. There we go. The first slide is going to cover our top 10 reasons to sell Scott and White Health Plan. Again, these are based on surveys that we've provided to our membership themselves, and surveys that we're beginning to provide out to brokers that we work with. Right now, from what I understand, it's the FMO shops that we're going to start targeting on this. And as Premier grows with their agent force, we're definitely going to be talking with y'all in the future on how our health plan's doing. But as of now, the top 10 reasons. The first one's going to be access to my doctors, my hospitals, specialists, and the rest of the ancillary services provided by my organization. The second is going to be our star rating. It is a 4.5-star plan in Central Texas. It's one of the few plans that's been in Central Texas from start to finish. And the way I like to explain it is, in the world of insurance, in the world of business in general, a company can come in from out of state, purchase an existing plan inside the state, and they're able in some cases to bring their star ratings from out of state. The bullet point number 2, you can go through our history and you can see where we started at 3.5, and you can see what we've done to build it to 4.5. Again, every carrier is shooting for that 5-star rating so we can market all year, and we're doing the same this year as we're focusing on those metrics. Number 3, we're going to offer a 0 premium MA only and an MAPD plan option in Central Texas. Historically, let's talk real quick. between Dallas-Fort Worth, the southern tip, which would be Hillsboro roughly, all the way to the northern tip of Austin, there has been no existing zero premium MAPD plan. This is the first year that the patients out there, that the market themselves are going to see zero premium plans being marketed. And I'd like to say that we were the only plan coming in with this idea this year, but with the cost plan exiting and the huge opportunity on the table, our competitors are coming out with some zero premium plans as well. Again, the biggest the biggest point of sale for us is going to be that access to 100% of our network. Number 4, it's access without restrictions, no referrals to see a specialist, limited cases for prior authorization, and again, those are only for high-cost services like surgeries or in-depth radiology that may take place. We are the highest NCQA-rated plan, the National Committee for Quality Assurance. We're the highest NCQA-rated plan in the Southwest. Our prescription drug, hearing, and vision care benefits are included in all plans. We do include the Silver and Fit membership with all of our plans as well at no cost to the membership. And number 8, the MetLife dental coverage. We do have denture coverage on this. I'm seeing a few standalones come out with this, but with our plan, coverage starts day 1, and there's no deductible for coverage as well, as long as you're going to a network dentist. We offer 2 types of dental coverage that I'll get into in a later slide. One of them is going to be embedded and included with the plan, and we have another option that's going to cost $20 additional premium for a $2,000 annual benefit. Number 9, simplicity. We are trying to remove any kind of tiered network system or any kind of preferred and non-preferred pharmacy structure that exists in our markets. The way we influence our competitors is we come out with that benefit first, and our competitors are watching to see how this works. Essentially, with my health plan, if they sign up with Scott and White Health Plan, they're going to have access to the entire BSWH provider bubble, as well as all national pharmacies across the country. We do contract with Sam's, Walmart, Walgreens, Target, CVS, any major pharmacy that you see that exists in any state, we do have a contract with them. And number 10, it's Texans serving Texans. Our home office is located right there in the heart of Texas in Temple, and we are one of the largest, I think we are the largest employer in that region. So we're big on turning around and serving our communities. Go ahead, John. All right, major changes to North Texas region. We are going to discontinue the Vital Traditions HMO. We are going to be pulling that plan off the shelf for 2019, and we're going to be incorporating that plan under the Scott and White Health Plan Company. Right now, it's owned by the insurance company of Scott and White. As we migrate that plan over, we're going to rebrand it as well. If you're on this phone call and you've contracted with us in the past, for the last 3 years, I've been tasked with developing the DFW market for my health plan. And one of the most confusing things that we ran into was doctors not recognizing our health plan, the doctor-owned health plan, because of the name. So Vital Traditions will be no more. We'll be rebranding something similar to Baylor Scott and White Health Plan in 2020, and we'll be coming back to the DFW market with a higher star rating at that point. So this plan exit in North Texas is nothing more than a CMS regulation, and we're coming back in 2020 with full expectations of picking up that membership and then growing from there. Senior care cost, we are all on the call because that cost plan itself in Central Texas will be sunsetted at the end of this year. And we're also going to have an extended window here for enrollment periods. I want to talk about the beginning of AEP, and the ability to flip my cost plan members to the new plans begins October 15th. Nothing has changed in regard to that. If you're currently working a marketing opportunity that exposes you to existing membership, get in touch with John or get in touch with myself immediately, because we can do something there to get you in contact with our existing membership, and there are certain programs that'll get you exposed and visible so that you'll have a good pipeline to go to when October 1st rolls around. But if you are currently working a marketing channel that exposes you to existing membership, CMS is permitting us a different level of conversation with our existing members only. So there is a possibility of being able to discuss 2019 plans in September. As long as you're contracted with us, I'm going to need to talk with you and interview you to make sure that you understand CMS guidelines. And as long as you pass those two qualifications right there, I'm going to stick you in an opportunity that we already have. Okay, two things to address on this slide. We will have a group of people of the 30,000 that will automatically transition, and we'll have a group of people that will not automatically transition. Let's discuss the differences in both of them. The first one, the people that will automatically transition, the most common question I get is that a dead sale for an agent? Is that a dead opportunity for an agent? The answer is no. About 8,600 people are going to be automatically transitioned, and based on the conversations, because you have to remember, we've met with these clients already face-to-face in April, and then we've communicated with them monthly since April, and they're very well aware of the timelines, the process, etc. But more than 50% of this auto transition population has already expressed that they want an agent to come out and explain the differences between the cost plan and the new plan they're being automatically enrolled into. That's where you will get credit for the sale on that group. VA and TRICARE coverage members, people that have senior care cost medical, but no RX coverage through Scott and White, these people will be automatically transitioned. I'm going to tell you right now, no VA or TRICARE member likes to be automatically transitioned over to something without having a discussion. This is by far one of the bigger populations that we're getting the calls from right now because they know the time period's coming up, and it's usually a proactive community. So jump in quick. We'll get you kind of set up on that. What I want to tell everybody on the call very explicitly is, even if that person has been automatically transitioned, let's say that they're transitioned from the cost plan preferred over to the preferred HMO, and they decide they want to go either down in coverage to the basic HMO, or they are select HMO, or they want to go up in coverage to the premium HMO, file that app. Grab that app. You will get credit for that sale. You will also become the agent of record for that member moving through time. So trust me on this. It's going to be an opportunity no matter where you're at. Now, our big opportunity, 2/3 of the membership, about 22,000 of these guys, they're not going to be automatically transitioned due to the fact that they have prescription drug coverage through a standalone. All right, every single one of these people are going to become a lead, and every single one of these people are going to call into my call center. So one of the things I can tell you, my call center is small. We're looking at maybe 55 people total, and they can't handle the volume of calls they're getting right now. So we're already starting to see some lead flow coming from this plan exit. This is the population we're going to target. How we're targeting them is our direct mail marketing campaigns, our retention efforts through direct phone calls, conversations with them, having these member events where they're face-to-face in-person trainings, and we're going to continue these throughout AEP. Throughout the SEP. Once we hit AEP, the company coverage and the company communication is going to stop, with the exception of the sales team here in Scott and White. I've got 7 call center girls, period, who account for about 500 sales a year. So 22,000 minus 500, we're looking at 21,500. It's still an opportunity for us, and believe me, this is going to overflow anything inside of our company right now. So get yourself positioned. If you're already working existing marketing channels, let us know what they are. You don't have to tell us how you're working them. Just let us know where they are so we can file them. We can start getting traffic directed towards your events if you have community events in the area. And we don't have to go through a corporate compliance process within Scott and White. Essentially, I'd be coming to support something that's existing and owned by the agency that I'm talking to on the phone right now. And that's how I approach these types of opportunities. All right, go ahead, John. Next slide. This is a quick snapshot. The left side is going to be where the people are right now, the current plans that they're on. I'm going to distribute this presentation out so you'll be able to look at all of the summary of benefits line item by line item. You'll be able to take a look at slides like this and understand where they're positioned right now in 2018 and where they'll be moving. A good example is that second group of people. I think it would be 1, 2, 3, 4. It would be boxes 5 and 6 on the left-hand column. the transition over to this Senior Care Advantage HMO Preferred RX, these people are stepping up in coverage, down in cost. It sounds funny, but it's the bulk of the people we're getting calls from right now because their costs are dropping. They're afraid they're losing certain levels of coverage. So what I'm suggesting with this slide is take a look at it, get familiar with the left column, and that way when you're on the phone, when you're in person, you run into any of these existing members, you can ask them what plan they're currently on, what Part D they currently have, and you'll already know what plan they're going to and how to have that explanation quickly. That's the big thing here is efficiency on time is going to maximize your income this year. Go ahead, John. You can, quick thing to touch on this slide right here. We just sent out communication to the existing membership. It hit homes today. That's where we're starting to see the spike in call volume. September 15th through the 30th, members are going to receive their annual notice of change. Hands down, 100%. That's where you're going to see the bulk of the calls coming in. The reason why is the documents that we're sending out themselves are CMS model documents with CMS model language. If anybody's ever dealt with the government, their language is less than soft. So when people, the general public, tend to receive information or communications from the federal government, a sense of panic is really their first reaction. And the best part of that is that sense of panic drives the phone call into my office and the subsequent lead that I'm going to distribute out to you. Okay. Go ahead, John. Okay, my swhp.guide. I'm sorry, guys. I've been doing this presentation 6 times a day now for the last 3 days. So I'm jumbling up words a little bit here and there. Give me a second. All right, so this website, myswhpguide.com, this is the communication that members have been receiving all year. It's a Medicare landing page that gives a lot of information on how this transition is going to take place, the timelines, the benchmark timelines that we're going to hit, and kind of what the expectation is at each timeline. If you want to get familiar with kind of how we're going, you can always call me, reach out to me and John, or you can go directly to this website and you'll see exactly what our membership is seeing. Go ahead, John. All right, the plan offerings themselves, we're going to have 3 MAPD plans, HMO plans in Central Texas, 3 new MA-only plans in Central Texas, and then we'll have a Senior Care Advantage PPO Platinum in Central and a PPO Basic for a total of 8 plans. Let's go ahead and skip. Our service area is going to include these 27 counties in the central heart of Texas right here. Bell, McLennan, Milam, I believe those are the top 3 in terms of membership numbers. If you go east of Bell, I think it's Limestone, Freestone area. East of McLennan County has got a good population, and so does Brazos and Washington down at College Station and Brenham. Let me know if you guys are working some marketing opportunities out there. We'll help drive the traffic through our customer service team. As they've received phone calls, they'll offer your events up to our membership that may want to attend. All right, we're going to go ahead and jump into the summary of benefits. Again, I'm not going to cover each of these line item by line item, so we're going to fly through it pretty quick. What I want to do is talk about concept on how we set these plans up, who your target audience is for each plan, or what we see statistically is the best way to say it. I did take a look at membership counts. We're not really allowed to see, exact information like male, female, or anything like that, but we are able to see where the distribution of membership is within the plans, and I'll kind of talk with you about how I've come to these numbers. The big thing you're going to notice with Scott and White is that we always offer a lot of plans. We start with a 0 premium option. We go all the way up to a $240 a month option in terms of their monthly premium. How we set plans up is typically based on how often they're seeing the doctors. So you're going to notice if their doctors are all in network with Scott and White, or maybe one or two doctors out of network, the HMO is usually a very good fit, and then we will pull that member in network. They'll basically stop the relationship with that out-of-network doctor, or we'll reach out to the doctor and contract them as in network. So we have two options on that side. But the first thing is we want to find out where they're seeing doctors. If it's all Scott and White, HMO is going to be your lowest cost option and most benefit rich. Again, there's limited restrictions when it comes to my HMO, with the exception of the fact that you have to stay with Baylor Scott and White Health. The PPO options for those folks that have one or two doctors outside, or maybe a host more of doctors outside of our network, and they want to continue that relationship. So we'll offer some out-of-network benefits on the PPO side. The biggest deal is how often are they seeing it every year? If we're able to have that conversation, we're typically more successful in developing a relationship with that patient and their primary care doctor. Now, I don't know about the level of training that's done on this in the insurance realm compared to the physician realm, but 100% of some of the cost issues we see at Scott and White Health is going to be misutilization of plans, improper selection of plans, a diabetic choosing a plan that doesn't cover diabetic services, stuff like that. We typically see that increases the problem between the patient and their doctor, and the patient won't go see the doctor. Well, what happens is the doctor's reimbursement is affected by that. Our doctors have the ability to fire patients, and our patients have the ability to fire doctors. One of the things that I'll talk about is if you want a consistent, stable book of business, my best marketing channel was always working with the physicians, understanding which health plans they worked with primarily, because that meant they were more efficient with those health plans. And then the next thing that I would do is focus on what are their patient needs. We can break them down into the people that are healthy, the people that are middle of the road, and the chronic condition crowd. And I'm going to have to handle each of the three differently. If I'm selecting the right plan for each of those categories of risk, my book of business doesn't move every year. And on top of that, it's a lot easier to get in contact with these people when it's time to move them and migrate them to a plan that may be beneficial for them. So that's one of the things I'll kind of submit to everybody on the call. It does help with stability if we're able to diagnose things according to which doctors they're seeing, how often they're seeing them, and choosing a plan based on their conditions that we're trying to finance or cover. So our select plan is going to be a $0. From left to right, you see the dollar amount increasing in monthly premium. But if you notice the benefits underneath, the more you pay in premium, the less you're going to pay in co-payments, the less you're going to pay in annual out-of-pocket maximum. So that's the design of the plans. The select goes with people that see the doctor maybe once or twice a year. The preferred, that's anybody's guess. I can see there's no rhyme or reason on who's picking that plan, with the exception of the fact that it does have a steady inpatient copay. So guys with heart attacks, I'm seeing more of them. The acute, scary, very major medical conditions that happen, I see them going towards the preferred more than the select nowadays. The premium option, it's $240 a month with Part D. Without Part D, it's $199. There's no deductible on any of the plans. You're going to notice my select has a $5,300 out-of-pocket maximum, and then it drops down to $3,400 for the remaining HMOs. On our PPO, the out-of-pocket maximum is $6,200 for the basic, $3,500 for the platinum. That platinum PPO, this is an interesting plan, and I remember when it was being developed, I was really excited once I started seeing market statistics. I want to tell everybody on this phone call right now, 286,000 people in Bell County alone are on Medicare, Part A and Part B only, which means they're also on a Medicare supplement. Those are people that we still see at our hospital. It's people my administration team is working to kind of get engaged in some of the educational events we're doing, which eventually funnel them into the health plan educational events. Our focus is to get everybody on managed care in our service area in the next 5 years. So if you're seeing people on Medicare supplements, this platinum product is the way to go. In the Central Texas region, the average premium for Medicare supplement with Part D is about $205 for people under age 71, 72. Once you hit 72, it goes up to 250, ranging up to 800. I ran into a Christian Fidelity that was paying 850 for a Plan F. So what I'm saying here is that the Platinum PPO, it's billable. It's billable under fee-for-service rules. If a member chooses to purchase a PPO Platinum in the state of Texas and they travel 6 months a year within the continental borders, we're going to cover them. And 99% of Medicare doctors out there understand how to bill a PPO. So the national network convenience factor of a Medicare supplement is exactly what we're targeting. And we're targeting it from the health plan side all the way to the doctor side. You're going to hear the message coming out of them that Medicare supplements aren't doing for anybody what they think they're doing. So we are going to be going after that coverage over the next 5 years as well. Okay, so primary care office visits, you go to the select plan at $0. This is the only benefit to me that didn't make sense. The preferred went up to $15 for the primary care copay, and then the premiums back down to $0. There is no copay for primary care visits on our PPOs, and our specialist office visits range from $40 to $0 on the HMO, $40 to $20 on the PPO. What I really want to touch on this slide is the diagnostic tests and the advanced diagnostic imaging. They've finally broken out some of these things, but there's still a range posted in my summary of benefits. I don't like that because people don't know what their actual costs are going to be when they go in for the services. A good way to establish rapport with a member is to be able to explain this logically and consistently. This is how you do it. Any basic lab services are going to be covered at no cost to the patient. They have a basic x-ray, any blood work, anything like that that comes as a result of a new prescription, a dropping of a prescription, or maintenance of a prescription will be at no cost to that membership. They have to go for a little bit higher imaging, an ultrasound. I've seen these. They literally put a patient out, they put a patient down, and then they slide cameras down their throats or other orifices. That type of imaging, I'm sorry, I just said that by the way, but that type of imaging is going to run about $75 on the select plan. The preferred is going to run a $15. The premium, they're going to have no cost. When they get into the advanced diagnostics like MRIs, CT scans, any kind of nuclear radiology, they're going to pay some pretty big costs if they're on the select plan. The lower level, let's say at that, on both the HMO and the PPO. It's going to be a $300 charge for each MRI or PET scan, CT scan, any of those things. So definitely if you have somebody that's dealing with a chronic condition or a condition that requires advanced imaging, start talking to them about the preferred or the premium at that point. Go ahead, John. Physical occupational speech therapy, these are comparable benefits across the entire market in Central Texas. So our benefits are what they are, and they're basically industry standard right there, so there's nothing great on that line. Where we start to shine is this inpatient hospital stay. We are reducing costs. Days 1 through 5 is $350 on our basic HMO, our select HMO, but on the preferred and the premium, we start to take away a lot of those costs. When I was telling you about men with heart attacks, the inpatient hospital stay on the preferred HMO is the reason we're starting to get those kind of calls and those inquiries. We have a current cost plan that's set up with a set fee for inpatient hospital stay similar to this preferred HMO. Matter of fact, the benefits look very similar to this preferred HMO. We have a lot of people on there that when looking at their claims data, it's an acute major issue that has happened. So that might help you in your presentation options when you're discussing with a client, you're doing your fact finding and you find out they have had some of those issues that are major, but not necessarily, they don't hang with the client for the rest of the client's life. Heart attacks, I've seen people recover and never have issues for 25 years after that. But that's where we typically see people go into the preferred. If you take a look at the Platinum PPO, the far right benefit has actually just been changed by Medicare. They did accept our bid to reduce that. The coverage on the Platinum PPO for inpatient hospital stay is going to be days 1 through 4 at $200 a day. That right there, we rarely see people going in and staying longer than 2 to 3 days. But that benefit right there, we don't anticipate being utilized a lot. Our PPO membership usually is our travelers. They're willing to pay the higher cost for out-of-network utilization. And to give you an idea, right now, only 2.5% of Central Texas is enrolled in a PPO with our company. So gives you an idea of how many people went HMO last year versus PPO. Go ahead, John. Skilled nursing care, we're going to cover this benefit for the first 20 days. It's typically prescribed in a Monday, Wednesday, Friday fashion, so 3 days a week. It'll last you 6 weeks at that point at no cost to the member. Once day 21 comes around, the costs jump up if they're on a select plan. Preferred, premium, those are manageable costs, $35 a day and $15 a day. But again, on the select HMO and the basic PPO, that's where they're going to incur a higher cost. Definitely let anybody know that shopping those plans where that exposure lies, but how often it's utilized is pretty rare. By the way, it would depend on how an inpatient hospital stay or how often that takes place. And again, we don't see that as much nowadays with the advent of the integrated care model. We're catching things early. Ambulatory surgical centers and outpatient surgery facilities. The reason they're separated is we do have ambulatory centers that are off-site of our main campus hospitals. Our outpatient surgery centers, we have those on-site at our main campus hospitals, and they're going to come at a little higher cost, about $75 more on the select plan, and much less if they go to the preferred or the premium and go to the outpatient surgery clinics there. The basic PPO, it's going to cost $350 for outpatient surgery at the facility. If they go to an off-site location, again, it's a $75 break at $275. Go ahead, John. Okay. These three are really the top three benefits right here. I just want to remind everybody on the call, any person that purchases an MAPD is given the same federal rights, options, and entitlements through CMS that anybody would have under the federal Medicare program. Reason I'm bringing this up is where we operate right now, these folks are very savvy or they're not. And part of the objections I see with my agents in the field on why they didn't sell product for MAPD and why they go MedSup is because of the travel benefit. Now again, going back to, and I'll argue this successfully with anybody, going back to the fact that these plans have federal protections, what I tell people is when they're shopping a Medicare supplement, it's typically for convenience on providers. I will compare that to the fact that we don't all grocery shop for bread at 7-Eleven. Why not? It's convenient. You can pull up right off of any road, jump in and out in 5 minutes, but instead we bear with Walmart. The reality is convenience doesn't necessarily equal quality. And if you're paying for convenience, which is what you do, then that doesn't necessarily equal the better outcomes or the better cost efficiency for that client. Every time I run into this issue, it's with a client that travels. And I'm a very involved manager here to the tune of if I start distributing leads out and an agent doesn't close within 50%, you can bet I'm calling every one of those leads personally. And I've got some sales skills, and I'm going to find out why that product didn't fit. And I'm going to do a quality assurance call and find out what was presented and what level was presented. And I'll tell you right now, with another FMO that had a call center with us, I found that 9 out of 10 times I closed the business against the agent and gave the business to another agent. That's something that I'll continue to do. I wear my company colors and I play my game with my team and for my team. How I do it is recognize the issues. Most of the issues that I deal with on that sale has to do with those travelers worried about coverage. If we go back to that explanation of, sir, ma'am, it doesn't matter where you go, I have to ask you this question before I jump into this conversation. Have you ever gone on vacation, sat on the couch, and while watching TV, just said, you know, I'm kind of bored today. I think I'll go see a cardiologist? No, I've never had a yes to that answer or to that question at all. So what I typically run into is, then what are you going to need the coverage for when you're traveling? Oh, I just want to know I'm safe if I get in a car accident, get a bee sting, seasonal allergies, the flu, a head cold. Typically, they're acute care situations. At that point, that's when I show them the CMS guidance on the fact that MAPDs have to cover you as if you're home in network seeing a network doctor. no matter where you're at in the country. You have a billing issue with them, you've got an entire company that can stand on your behalf and advocate for the resolution of that bill. And here's the point blank thing that I like to tell folks. Ambulance is going to be covered no matter where you're at within our U.S. borders. Emergency and urgent care, they're used for different circumstances. But if you see any charge different than what you see on this piece of paper, you need to reach out to me as soon as possible, which would be you, the agent, and then you, the agent, needs to give me a call as quick as possible. 100% of the time I see an issue on out-of-state billing problems is because an alphanumeric diagnosis code or current procedural terminology code or HCPC code is coded incorrectly. It takes 48 hours for me to figure out where that problem is, or for one teammate of mine to figure out where that problem is, get the claim resubmitted, and then the charges look more like what you see on the screen. My major thing is there are no more restrictions on MAPDs for people that travel. So anybody that takes that messaging and is able to get out there successfully enroll a lot of our clients, you can bet that in the future I'll be partnering with you and I'll be using you in every market we expand to. So I'm saying all this to kind of present an opportunity for folks on this call that are very efficient at understanding where this model is going for fee for value, because that means Medicare Advantage is going to be the future. All right, go ahead and you can skip. Durable medical equipment is 20% across all plans. That's going to be your wheelchairs, any of that stuff, your crutches, any of the durable pieces that they may need. We've got 277 vendors in our network that they're able to set up with. I'd advise they go through their primary care physician. Typically, they have a line on how to get that equipment delivered faster than if they go through the customer service process. All right, the Senior Care Advantage out-of-network benefits on our PPO is going to be 35% coinsurance to the member on the basic, 25% on the platinum. The biggest difference is there's an annual deductible on the basic PPO. There's no deductible on the platinum. When we're talking about the $10,000 out-of-network maximum out-of-pockets, that is an aggregate maximum out-of-pocket. If they hit $6,200 on the basic PPO in-network and they decide, let's say they get diagnosed with cancer in November and they need to go to a pretty high-cost cancer treatment facility in Houston, great. We'll start working with that approval process and get them in. They'll be exposed to $3,800 left over. And once they hit the $10,000 maximum out of pocket, we will cover the charges, any Medicare approved charges. On the HMO side, we don't have any out-of-network coverage with one exception. That exception is we're working in a rural area. CMS has time and distance or network adequacy rules for all Medicare Advantage plans. That means a patient has to be within a certain time and distance of that provider. I've run into a problem with rheumatology. If that provider is scheduled out 2 months and that member cannot get into a rheumatologist in network, get in contact with your upline. I'm able to lean over on network administration and we do what's called a letter of agreement. They have a provider willing to accept customary Medicare charges, 100% of Medicare. We'll write a one-time agreement for that patient. They'll be able to see that doctor is in network. Go ahead, John. Okay, real quick, the medical only plans, it's going to be the first year that Scott and White's offering a true MAPD medical only. We did have a cost plan medical only, but again, that has whole different rules on whether and when or how you access out-of-network coverage. As we move towards these and migrate towards these Medicare Advantage plans, when they get on MA only, we're definitely going to want to make sure we're going to want to verify a few things. The first thing is we need to let them know if they have existing drug coverage and they elect to go MA only, there's a possibility that that can start a late enrollment penalty. That's my biggest one. I wish that was bullet point number 1 here. Okay, number 2 that we want to focus on is going to be when they transition, if they have existing drug coverage and they transition over to our MAPD with drug coverage, we do have to let them know that our plan is going to cancel their standalone PDP. And as they transition into our MAPD, they're going to still have drug coverage, but they'll be automatically terminated on that standalone. Okay, and then last one, but bullet point number 2 on the screen is that we don't permit medical coverage on the MA side with a standalone PDP. Private fee-for-service existed in this market for a long time. So some of these members are going to be confused as to why they can't pick an MA only and then go for a Part D. I'm bringing that up because I'm already anticipating a problem, and that problem is going to be this. Membership is going to switch over from this cost plan with a standalone PDP to an MA-only product, and then at a later date, despite what you agents have told them, they're going to go online and sign up for a PDP, and that's going to kick them out of their full-on health coverage and prescription coverage. Make sure that you let them know if they go MA only, if they enroll in any standalone later, if they do any kind of Part D work, they modify and basically sign up for a plan on that side, they're going to lose their health coverage. So it'd be a good point to talk about the MAPD at that section. That just brought up something that's not listed as a selling point, but I do want to talk about it real quick. The average premium that our membership is paying right now is about $350 to $400 a month. That's with their health premium, and whether or not they're on a standalone doesn't matter. We're watching those costs creep up as well. So a big value statement that you're going to have when talking to these members as they transition is no matter what they're doing, they're going into a plan that has more coverage at less cost. So that's one of the things that you just definitely want to assure them of as you go through. Go ahead, John. All right, the Senior Care Advantage prescription drug mail order program, we can set it up through customer service. What you'll want to do is just provide this phone number to the membership when you enroll them if they elect for the mail order program. If they do elect to go mail order, it will give them a cost savings. They'll pay 2 months worth of copay for a 3-month drug supply. Go ahead, John. All right, we did change Part D vendors this year. We are letting go of the Salado and Argus pharmacies. They've been good partners, but not great partners, and we definitely want to partner with some of the industry leaders in this area. Pharmacy benefit management is a billions and billions of dollars a year industry. We want to make sure we're spending our money correctly and appropriately for our claims. OptumRx is a national organization. Everybody's familiar with them through United Healthcare. They will be working with us on our PBM. They have already come in and done some pretty unique formulary changes. I'm thinking everybody on this call is going to be excited about our formulary once we release it for 2019. Go ahead, John. We have the same drug tiers, tier 1 through 5, 1 being the lowest at preferred generics, tier 2 is the generics, tier 3 preferred brand, tier 4 non-preferred, tier 5 is our specialty. Again, we don't have preferred or non-preferred network pharmacies. Our patients can go to any big box pharmacy that exists. Go ahead, John. All right, here's some of the costs. The benchmark limit this year for the initial coverage phase is going to be $3,820. You'll see on the screen, depending on which plan you choose, again, you go low in premium, monthly premium, you're going to pay higher copayments. The higher you pay in monthly premium, the lower you pay in monthly or in copayments. So that's going to be our benefit structure. And the big notable on this side is going to be the deductibles. We do have deductibles that apply to brand name drugs and up. Our select plan starts at $300, the preferred at $100, and the premium down to $50. The only plan that does not have a drug deductible is our Platinum PPO. I'll leave this slide for everybody to kind of review, and when I distribute it out to John. Go ahead, John. All right. The prescription drug donut hole. We did include this in the presentation, not because we don't think agents know about this. It's because CMS is doing a lot of secret shopping in 2017 for plan year 2018, and they're going to do more this year. We have a direct line with Mark Hawley, our regional CMS manager, and he has informed us in the local DFW market they will be looking for full and complete Part D explanations. What we want to do when we're talking about Part D is kind of make it a dance where you have 5 steps that you know you got to hit each of the 5 steps no matter what happens when you're talking with a member that elects Part D coverage. The first thing you need to go through is how companies structure their formulary. They do it in the form of tiers, Tier 1 being the cheapest, Tier 5 being the most expensive. They break down the cost, and the cost will be different from company to company for each tier. The tiers can be found in the the prescription drug formulary provided by the health plan. Once we get into that conversation, we're going to have to talk to them about the coverage levels provided by Medicare. What is the initial coverage level? What does it go up to, the $3,820? What is the donut hole? It's coverage between $3,820 and $5,100 retail costs from Medicare. And then we have to describe what that looks like from a patient perspective. Well, Becky Johnson, when you first select coverage with this plan, your antacid medication is going to cost you, the Tier 3 with us, it's going to be $45. The drug itself is $500 for Medicare. So every month they're deducting $500 from $3,820. Whenever that dollar amount of $3,820 reaches zero because you've spent $3,820 filling your drugs at $5 donut hole or the coverage gap, you'll be responsible for 37% of the cost of generic drugs on most of the Scott and White plans, with the exception of the premium HMO and the platinum PPO. Other generic drugs, 37% across the board if they fall outside of the Medicare formulary. Think narcotics. I'm seeing hydrocodone, stuff like that getting pushed off Medicare formularies. So when we say other generic drugs, typically referring towards those generic narcotics. Brand name drugs, Mrs. Johnson, you're going to pay 25% across the board once you hit the prescription drug donut hole. So for that $500 medication, you'll pay what, $120 every month for that drug. This is a good point where you can start to bring in that conversation of the fact that CMS is trying to eliminate the donut hole by 2020. But as of now, let's say that you get into the donut hole, and with your drug costs, you end up spending a total of $5,100 out of pocket. Once you hit that number, Mrs. Johnson, you're going to enter what's called the catastrophic coverage phase, in which you'll pay the greater amount of 5% or $3.40 for generic drugs. I know it's confusing math, and I'm not expecting you to memorize it. It'll be located on our plan materials that you can refer to at a later date. But you'll be responsible for the greater of 5% or $3.40 for generic drugs or $8.50 for all other drugs. And that's one of the ways that we want to explain it. Make sure you're hitting the formularies, the tiers, the cost, how to find the drug in the tier, the initial coverage under Medicare, the coverage gap, and the catastrophic phase. And last thing they want us talking about is late enrollment penalties. If you've already had that conversation, you don't have to, again, enter it here. If you haven't, it's a good place to start. This is where I'll bring it up. I have some people that have elected to go outside of Medicare Part D, and they've decided to not purchase coverage at all. Want to let you know that's going to cost you as well. Here's how it costs you. And then I kind of explain the monthly penalty depending on their level of understanding. If it's a savvy business person, I'm going to explain it full on. If it's just any general person out there that doesn't know anything about insurance, I don't want to overwhelm them by getting into that in great detail. I'll just keep it high level, and then again refer them back to customer service or myself when that issue arises, if they ever run into that concern of theirs. Go ahead, John.
Actually, Chris, I'm going to interject something here just very briefly. Part of what you're going to get as a person expressing interest in today's webinar is information on the LIS and MSP programs, because everything that Chris went through and described to you would be overridden by LIS participants, the extra help piece. And so the recording of that webinar will be helpful for you as well. And at this point in the conversation, it would behoove you to bring up the possibility of that sort of assistance as well to help you not only sell this plan, but keep people on it. So that will come as part of the follow-up, and I'll go back to mute.
Thank you so much, John. You brought up a great conversation right there that I totally whiffed on, and I apologize. Let me just identify the areas real quick. your Killeen area, just outside of Killeen, your Copperas Cove, your South McLennan or South and West Bell County. We've got a huge Medicaid population. You're noticing that none of these plans say SNP on the top of them. The reason why is we don't have to manage that aspect of it. Our doctors already are engaged with Medicaid. They're fully educated on how to bill Medicaid. So there's no need for us to develop a special needs product, because all that does is wrap the payment and the responsibility of collecting payment into the carrier's responsibility as opposed to the doctor's. Well, that leaves the doctors the ability to go ahead, if they're efficient and proficient in billing Medicaid, then we're able to see these Medicaid recipients, keep them on their Medicaid plans, and still service them on these Scott and White HMOs. But a good point that John just brought up, and I usually backdoor into this, is while you're in an appointment, some of these Medicaid and LIS recipients do not look like that. In DFW, I can almost pick them out. In Central Texas, I can't. I don't know who's on LIS and who's not. And a lot of the times how I find that out is while I'm doing a Part D review or analysis, what I'll run into is they're given a brand name drug that I know is a tier 3 through other carriers, through my product, and they're paying the Medicaid rates that I just described on the last slide. I think it was $255 or $855 is a typical charge I see for brand name drugs for people on LIS. If you're going through that fact finder and you run into that, definitely you can skip parts of our presentation at that point. Like John said, you don't have to get into this donut hole conversation. Educate them on what the LIS benefit does to counteract the donut hole. That's going to be a good way to keep yourself compliant. And I'll tell you the truth on this. Some of the people that I've seen successful with this population and keeping their books stable, I never really had the greatest success in keeping the LIS book stable. But some of the guys that I've seen do this, what they're doing is they're sitting down and they're educating these patients on this information, and the patients are understanding it. When the patient can make that connection, they're starting to learn things about utilization of their product that may lead to them getting out of the LIS status. So that's something that you want to keep in mind. The other thing is my company offers through my hospital system their own charity program. We have our own Medicaid program that's privately funded through Baylor Scott and White Health Hospitals. It is not open to the general public, and it's initiated by the primary care office. But if you're talking with a member that's struggling with their finances, they're struggling to pay co-payments or struggling to fund their drug costs, let them know that they can reach out to their PCP. There is a charity program that Baylor offers, and their PCP will get them in contact with the eligibility requirements, and they'll get them in contact with the application process as well. All right, go ahead, John. You can skip this slide too. All right, coming down to the home stretch. Our Senior Care Advantage PPO in North Texas. It's going to be our only product in North Texas, and I'm going to tell everybody on the call right now, it's probably the most expensive PPO I've seen up here in this market. So we're not anticipating a huge membership number in that plan, but what we are seeing is loyal Scott and White membership in Dallas is asking to go into a $41 a month PPO just to keep their Scott and White coverage. Right now, it's only 2 out of 10, maybe 20% of our people that are asking about this move. And so far, we don't know how many people are going to make the move, but I want to make it pretty black and white for everybody on the call. Our product in North Texas is not even in the top 5 in terms of cost. Where we have still a value is that it is one of the few plans that's located in North Texas that gives you 100% access to the Baylor Scott and White Health doctors. All right, the plan benefits themselves are very similar to 2018. So I'm just going to run through real fast. No change on the annual out-of-pocket maximum, the PCP copay, specialist office visit, or diagnostic test, x-rays, lab services, and advanced diagnostic imaging. No change on the inpatient hospital stay. The outpatient hospital stay has increased to $350 a day or per stay. The ambulatory surgical center has gone down to $250. Go ahead, John. Ambulance, emergency care, and urgent care. The cost $350 for the ambulance, the emergency care and urgent care is $90 and $50 respectively. And again, the same DME, 20% as the Central Texas products. When we're talking about utilizing out-of-network benefits, there will be a deductible on this plan as well. $750. Basically, the first $750 of medical costs are going to go on to the client. And after that, they'll be responsible for 35% up to $10,000. Go ahead, John. The prescription drug benefit does have a deductible for the brand name and up of $300. And again, it follows the formulary coverage amount for the preferred and the premiums in the Central Texas product lines. $4 for your tier 1, 14 tier 2, 47 tier 3, 99 tier 4, and 27% for your specialty drugs. I'm not really seeing a lot of specialty drug utilization other than infusions. If they're on an infusion that is not a Medicare approved cocktail, meaning the drugs that are being used in that infusion, maybe one or two of them may not be Medicare approved. That's where they're going to see that 27% specialty drug on infusions. Most other infusions are covered under Part B or Part D on Tier 1 or Tier 2. Go ahead, John. Okay, let's jump into the value-added benefits. It's one of the bullet points on our selling points in Central Texas and in North. The vision care itself is, you can skip to the next slide, it's got a benefit grid. But the vision care itself is going to be provided through Superior Vision, and this is for your basic eye exam. If there is any medical condition attached to this, they need to be seeing an ophthalmologist, which will be a specialist copay in whatever plan they choose. In Central Texas, however, we do have optometrists within the Scott and White network. So clients can use Superior Vision, or they can use one of our network doctors that they can find on swhp.org. The eyewear allowance is going to be $125 a year for every plan that we own. Your client can basically go purchase any frames they'd like, and the first $125 will be compensated by Scott and White. Go ahead, John. Hearing coverage, we used to partner with Hear USA. What we noticed is there are a lot of hearing aid vendors out there that are cheaper. So what we did was we removed the network partnership. And how we're allowing members to access this benefit now is they can go to their routine hearing exam provided through an audiologist or through one of their specialists in Central, and they'll pay the copay that you see on the screen according to their plan. The hearing aids, however, are a first dollar reimbursement benefit. So they can choose any vendor they want for their hearing aids. They can go on Craigslist or eBay if they want to. We just need to see an official receipt. And how that happens is they'll submit it to customer service, and Scott and White will reimburse the first $1,000 on every plan of ours except for the preferred HMO. Go ahead, John. Gym Fitness Club memberships. Silver and Fit exists in Central and in North Texas. They partner with various gyms similar to Silver Sneakers. You can go to their website to find the provider list in their area according to the zip code and according to what services they'd like. If they'd like to get into a lap pool, they'll be able to filter out options that have Olympic-sized swimming pools in there. If they want to do aerobics classes, that stuff is listed on the membership as well. And if for some reason they don't want to exercise this benefit in a public setting, they can also opt into the at-home fitness program. They're going to receive a bundle of supplies, some dumbbells, rubber bands, hand bike, a few things on a few other equipment pieces for stretching, and then they will receive a full complimentary DVD package that walks them through the workout programs themselves. If they choose the at-home fitness program first and end up deciding that at a later date they want to join a gym, they're more than welcome. They'll have to call Scott and White. Scott and White will get in touch with Silver and Fit. They'll alter the membership to a gym or a commercial membership. And that member will have to go to the gym after Scott and White is notified. We'll notify the gym. The gym will be ready for them. They'll go in and they'll sign up for their membership. In years past, exercising this benefit, members used to be able to jump from gym to gym. Example, in DFW, they could go to the Jewish Community Center in the morning, and then they could head to Lifetime Fitness in the afternoon. That's no longer the case. Silver and Fit, as well as some of the other people that run programs like this, they're wanting to track their membership numbers and their partnerships with their gyms a little closer. So they do require a 30-day membership. Your member can switch gyms if they don't like it after the first month, but they will have to stay with whatever selection they choose for the remainder of the month. Go ahead, John. All right. The dental coverage. We noticed a need, and we also saw a gap between the utilization of the MetLife standalone dental that we were offering, or basically the policy rider that we were offering in years past. And what we decided to do was to bring part of that benefit in-house. It's still administrated by MetLife, but it's more or less works like a reimbursement benefit. There's $1,500 for each service. I'm sorry, $1,500 a year included in all of our HMOs in Central Texas, and it's included in the Platinum PPO at no cost to the membership. You'll be able to go get $1,500 worth of dental services every year and not pay an additional premium. MetLife still offers the $2,000 a year coverage. It will be a $20 additional cost to the member on top of their plan premium, but if they elect to go with that coverage, it will add the $2,000 to the existing $1,500 worth of coverage. There are some restrictions on that in terms of what services are covered. From my understanding, extractions are covered. The problem is anytime a tooth needs to be put back in, with the exceptions of dentures. As long as they need dentures, MetLife will cover it day one all the way up to $2,000, and the member will pay the remaining costs. What we tend to see on the dental benefit for MetLife, though, is if a person gets an extraction, getting something put back in like a false tooth or some sort of implant, that is not something that's covered. So do let them know there is some cost exposure when it comes to dental on Medicare. Go ahead, John. Oh, wait, hold on. Sorry. Go back. Okay, last 2 points on this slide. In order for your member to find a provider, or for you to find a provider for your member, you can go to metlocator.metlife.com. I'd just save it in your phone, or they can call that 800 number that's listed on the screen. It's a dedicated customer service line to Scott and White members only. Here's how they want to do that phone call. Matter of fact, if you're an agent on this phone call, I would not advise your member to call MetLife. The reason why is they have to give their membership ID number instead of their Social Security. Depending on where their call is routed within MetLife, we have run into customer service reps with MetLife that don't know that. So they will tell your member that they don't have dental coverage. They're not in the system. If any time you find that your member is not in the system, or your member is reporting that they spoke with MetLife and MetLife saying they're not in the system, 100% of the time it's because that customer service rep is not looking it up the correct way. That's why I advise every agent, go ahead and do the dental search or the dentist search yourself, and then show them 2, 3, 4, 5, however many options you want to in their area. But if they call that 855 number, they're going to be asked to provide a Social Security number. You'll have to coach the member on the fact that do not give them a social. Give them your Scott and White member ID number in place of your social. They will find your member at that point. They'll be able to provide and process anything that member is requiring or requesting at the time. And the last thing is when looking at metlocator.metlife.com, you want to use the MetLife PDP Plus network. Go ahead, John. All right, last few slides. I'm just going to paraphrase these fast. Our Medicare Advantage site is advantage.swhp.org. This is going to allow you to find providers. You can go to swhp.org, and on our main website, you can find providers and find drugs as well. But advantage.swhp.org will help your Medicare members navigate our space. Go ahead, John. The first step in the process is going to be to select a county that they live in. So you'll have had that conversation, done your fact finding, you know they live in Coryell County, you're going to select Coryell County. It's going to limit you to a certain number of plans. Once you get to the point of online enrollment, though, you want to go to our website, click the Enroll Now button on the Medicare website, off to the left. You can just fast forward, John, one slide. It's going to bring you to the county selection page. You're going to notice that drop-down menu right underneath county selection. And that drop-down menu is going to include all 27 plus 6, so 33 counties that we exist in. You're going to select the county that the member goes into. Go ahead and click Next, John, or that the member resides in. and you're going to come to this page right here. This is where it limits you to the options that exist in that county. You'll go ahead and choose the plan by selecting the blue Choose Plan button underneath the premiums that you see that your client selected, and it's going to bring you to the next page. It's going to ask who you are. Are you a beneficiary enrolling on your own or a broker or agent? You're going to select option number 2. Go ahead and skip to the next slide. Skip to the next one. And option number 2 is going to have this drop-down menu. It's going to request your agent NPN and your name first. I don't think you have to put in your whole name. You can just punch in your last name, and most of the time it'll pick you up. But once you select an NPN or input your NPN and select or put your name, you're going to select validate number 3 down there, and it's going to auto-populate that field that you see right above it that says agent email and field marketing organization. So that will tell you you're already in the Scott and White Health Plan system, you're contracted, you're vetted, you're credentialed, and you're fully ready to sell. At this point in the process, if you click validate and you don't see anything other than what I've just described, if it says there's an error, it does not auto-populate, get in touch with me as fast as possible. Shoot me a text is the quickest way. Go through John in the upline first and then shoot me a text. What's going to happen is Premier is going to reach out to my licensing division. I am too. We're going to have the same story, and you're going to have whatever requirements missing emailed out to you and in a request form, and all you have to do is copy the document to it or attach the document to the email, forward it back to my home office, and we'll get you ready to sell within 20 minutes. So in some cases, you can be in the house and run into this issue and give us a call, and we'll be able to fix it while you're still in the house and give you the ability to take the application. All right, so let's assume everything's gone well. We click validate. This is exactly what you'll find if there's an issue, is that little red notification right there that says agent NPM name not found. Okay, skip to the next slide. That's that point you'll want to call me. Okay, once you've validated and it's gone through correct, you're ready to sell, then you'll click continue. Go ahead and skip to the next slide. Okay, on the next, after you click continue that was on the previous slide, though, you'll be asked to check an attestation box at the bottom, and that'll bring you directly into the online application from there. You're going to input your patient demographic information. You're going to input all their, whether they're on current prescription drug coverage or not, replacing a product or not, etc. Page 3 is going to contain the premium payment information. Page 4 is going to have the disclaimers and the signature page. So at this point, we've already gone through all of that. We've submitted the application to Scott and White, and I want to take the opportunity right here to discuss why this is so important. Online applications are going to be key this year for a host of reasons. I'm going to give you the top 3. The first one is Medicare wants all of us migrating towards that, period. They don't want to use paper stuff in the future. I can understand that. Number 2, it provides a collective and referenceable document that I can go back to if there's ever an issue with that client's acceptance. Occasionally, we'll have apps that pend. I'll be able to go in and see those this year, and if that application pens, I'll be able to track it back to the online application ID number, if there is one. If it's a paper app, it's going to extend the process of me figuring out who the agent is and getting in contact with them before the application is canceled by Medicare. So first one is Medicare requires it. Second one is it's just more efficient for me on the on any kind of application errors. And this is the third and the biggest one. Commission problems. If there's ever a commission problem where a policy is not paid for, I need proof. I cannot have a phone call and that be the only thing. I can't have an agent text me and that be the only thing. I actually need to see proof that the application was written to be able to resolve it quickly. If you're able to provide to me this page that will basically auto load at the end of every online application that you submit, screenshot it, save it to your computer, take a picture with your phone. I don't care how you retain this information, just retain it. because if you ever have a commission issue, this is the first thing I'm going to ask for if it's an online submission. If it's a paper app, I'm going to ask for a copy of the paper app. You give me those two things, I can fix your commission problems inside 10 days. If I don't have those two things, I don't care what the situation is, if I don't have those two things, it's going to take me a minimum of 30 days. So let me know when you have a commission problem by sending me this page right here. Okay, the last thing on this slide is what to expect next. I've worked with call centers and I've worked with field agents for the last 10 years. I was one, and I'll tell you the truth. With AEP going to this October 15th to December 7th format, Scott and White only sends out ID cards twice during that period. We will batch ship every enrollment from October 15th to November 10th on November 17th. It'll hit homes on November 24th on average is when that happens. But we do not ship ID cards in 10 days like some other carriers might or like people expect. You want to set the expectation correctly so that your member doesn't get fearful that you didn't do something right or the health plan didn't do something right and they jump ship. We have seen that happen in the past, or they've just gone ahead and canceled the application because they didn't receive it and the agent told them to expect to receive it. So do yourself a favor and just set them up with the right expectations. That's going to be, the welcome letter will be received within 10 days. If they're enrolling during AEP, they're going to receive their ID cards either closer to Thanksgiving or towards Christmas if they enrolled after November 10th. But either way, the policy ID cards, the policy documents, a copy of the formulary, and a copy of the provider directory will be mailed to every client enrolled during the annual enrollment period prior to the start of their policy. So that's one thing that you can assure them of, and then you can explain the process with Scott and White. All right, go ahead, John. You can basically keep your hand on the arrow button now. Agent marketing pieces, we're going to have some customizable documents available out there. They're not through the CMS approval process yet. I don't know what the timeline is on that, but we're anticipating before the end of this month. If you want to fund or finance your own agent mailer, reach out to John and let him know, and I'll start getting things together for you. We're going to come out with about 4 pieces that are direct mail targeted, 2 pieces that are advertising events, and 1 piece that'll have a generic educational language on it for anybody running educationals. Go ahead, John. Ordering enrollment materials from us, we're going to begin the broker roadshows, which are the product rollouts. Essentially, I'm going to be running through this presentation in different locations in person in Central Texas. I believe John has it in this presentation. But if you attend one of those roadshows, come see me in person. We'll go ahead and submit the material request right then, and we'll do it from my email. But if you have to do it on your own, go through SWHP agent support at bswhealth.org, or you can call the agent support team at the 800 number listed. If you email them, CC me on the email. It's one of the quicker ways to ensure that your stuff is going to be sent out faster, is the best way to say it. Just make sure that somebody like myself or Jared Knorr is CC'd on the email, and we'll be able to kind of drive the follow-up from our side of it. You'll want to provide the name of the material you're requesting. You want the HMO material? We're going to have preferred, premium, and select all in one HMO book. We're going to have basic and platinum in one PPO book. So let us know what product line you need it for, the quantity that you need. If you don't tell us there's an event or some other reason that you need more than 5, our home office is only going to ship out 5 of these enrollment kits at a time. If you have a public event, a health fair, anything like that, let us know. We can ship out 25, 50, however many you need at that point. But the last thing you want to include is your name and the shipping address. FedEx does not deliver to P.O. boxes anymore, so please don't put a P.O. box. I had a lot of returns last year based on P.O. boxes in the Central. Go ahead, John. All right, the price to play the game. What do you need to have done in order to be ready to sell? We're going to need a copy of your 2019 AHIP, your product training. It's offered through Litmos. If you haven't received that yet, reach out to John. He'll get you in contact with the link, and we'll email you a personalized link. It's not a link that can be forwarded to another agent. So the product training itself is 25 questions. Some of these are tricky. This is not like every other carrier test where we can just bomb through it and on common sense and score 100. Some of these are going to be tricky and they're going to make you think. I believe out of 25 questions, you can only miss 3, if I'm correct on that math. And what I've found is that we've got a large number of people failing this exam this year. If I give them a call and talk with them about their failures, 100% of the time it's because they're going through it too fast. So the only thing I'll caution you on our product training is make sure you read the questions and understand some of them are going to be tricky. The true falses are killers. All right, the last thing, you have to submit your attestation that you've read the documents, the Medicare Part C and D fraud, waste, and abuse training, which was a part of AHIP, and then the Medicare Learning Network that we have. That's part of your agent contract and your sales code of conduct with Scott and White Health Plan. Go ahead, John. There is a deadline this year of September 30th, by the way, though. I'm going to tell everybody on the phone call, if you guys wait till September 1st to contract, you will miss the first week of AEP. The state still has to add the appointment to your license before we can stamp you as ready to sell, and we're at the mercy of a bureaucracy at that point. So know this, they're taking 2 to 3 weeks to get those appointments processed, and as AEP comes closer and more agents jam their contracting paperwork in our pipeline, the longer it's going to take for the state approval. So jump on it as soon as possible. Okay. Important numbers to know. All the plan documents are going to be listed at advantage.swhp.org. My agent support team is available 8 hours a day right now, and I believe during AEP they're going to extend their hours. But they're available through email contact at the email address on the screen and the 800 number listed. Our fax number for agent support is listed there as well. That's going to be needed for any contracting documents that may be missing requirements. And then myself and Jared Knorr are listed on the screen below that. Got the longest email in Baylor Scott and White history. So once you input it once, double check the spelling and save it. There's a lot of room for error in my email address. All right, and then the last thing is our SWHP customer service line will be available at 7 a.m. to 8 p.m., 7 days a week during AEP. All right, John, go ahead. So numbers for MetLife, Silver, and Fit Superior Vision, all of this is listed on the inside of the pre-enrollment kits. And again, guys, I'm going to distribute this copy out to John. Actually, he already has it, so he has my permission to distribute it out to you guys from here on out. Any questions? Oh, thank you, John. The road shows that I was talking about, the in-person trainings. It's a good chance to come meet our sales team leadership, myself, my counterpart, Jared Knorr, and other area agents. We will be doing these as a general show, so they're not FMO specific. If you guys want to set up any specific trainings following the road shows, we can do that too. But as they're listed, on the 27th, I'll be in College Station. I'll be in Georgetown the day after that, Marble Falls after that, Temple on the 30th. On the 31st, I'll be drinking the biggest beer on the planet. And on September 5th, I'll be at the Hilton in Waco. So feel free to show up to any one of these events. We'd love to meet you face to face. I like face-to-face interaction. It's great. It gives me a chance to see what your selling style is, kind of how you carry yourself, and then gives me a chance to kind of deep dive into some of the channels that we may have open for you. Gives me a great idea of your level of experience too. So I invite anybody on the call, new, old, tenured in this business 25 years, it doesn't matter. Come to one of our shows. I'd love to meet you. And I believe that's it for the presentation today. I think we'll open it up to questions now.
Two quick questions for you, Chris. One, there's the question on why do we use a county drop-down instead of a zip code drop-down in part of the online process?
So county over zip code, we do have some places where that zip is, it falls within 2 counties. We ran into it with Dallas and Denton County in North Texas. The simple answer is this is the quickest way to ensure there's no error.
That works. The second question is, since we set up the contract for agents to have the possibility of marketing both 2018 and 2019 product as someone comes on as a newly contracted agent, if the agent is only interested in the opportunity moving forward in 2019, how do they bypass the 2018 certification?
If you just go ahead and do the 2019 certs right now, it'll account for 2018 as well. It is retroactively applied.
That works. So those were the only two questions that we had per se. We'll be sending out a follow-up presentation piece with this presentation in PDF format and links to the recording to today's presentation, the recording to the presentation we did earlier in the year about the opportunity, and give you a link to the LIS MSP presentation we did as well. A quick couple pieces of help for you if you need discounted E&O coverage. We have that available through Premier Marketing, along with a way of getting your licenses kept up to date with continuing education credits, a simple way to contract. This does not work for the Baylor Scott and White contract, however, so we'd want to do that separately. We have additional trainings that will be scheduled and other recorded trainings from past presentations that are available to you. The electronic means of enrollment through Scott and White are wonderful. For other carriers, we also have additional electronic means of support, including a revamped Medicare center. I think that will be of interest to many of you. We do have a program as well that can help you work through social media without working through it. You can hire basically someone to do that for you. We have an assortment of lead programs that are in place that can help you. A couple of things that come into mind very quickly when you engage into the Baylor Scott and White opportunity is consider some additional work in faith-based opportunities and in provider marketing opportunities, and we'll go through that with you on a one-off basis as well. We do have our mail support program that we work through with Premier, and as you come on as a contracted agent for Baylor Scott and White, there are other possibilities we'll want to discuss with you. So we want your business. We're asking for your contracts. We want to make certain that this is a timely way of approaching this opportunity. And as Chris mentioned, okay, it's the 15th of the month. It means we're halfway through August. And Chris mentioned that we need contracting in by the first of the month to make certain that you're up and ready to go for the first opportunities in the enrollment periods as we roll through October 15th. This is some contact information of our office here in Dallas. There are also opportunities for you to reach out to the marketer you may already be engaged with. We strongly recommend that you do that, and you can reach that through the 1-800-365-8208 extension and ask for your marketer, and they'll make certain that they hook you up. We're going to make certain that they have all the information you need to take advantage of this opportunity. And I want to thank you for sticking on the line with us today. We had a lot of information to throw at you fast and furious, but we wanted to make certain that we do things as thoroughly as possible. I want to thank Chris for coming on the line and spending some time with us and going through the program as thoroughly as he did. If there is a source of truth within the Baylor Health system for Baylor Scott and White health plans, it is Mr. Iona, and I thank him for that opportunity to work with him. That said, I want to thank you for coming on the line with us today. We have reached the black screen, which tells us that we're finished with today's presentation. We look forward to visiting with you in the very near future and on an ongoing basis, and we wish you good selling. So much for that, and thanks so very much. We'll talk to you soon.
Thanks, everyone. Thanks, John.